I'm Dick Davis. This is the seminar called My 5 Wishes, and that was picked because if we titled it End of Life Planning, no one would come. And we had experience with one of those. So this program is being taped by cable CATV. We will get a link on our website to theirs, so if you missed one, you can sit and watch it. So that'll come out here shortly when Linda gets all the details. But originally we thought we'd put it on our website, but it's too complicated and no one will get to it, so it'll have its own. The club provides the facilities for us and refreshments. If during the program you want what's over there, just feel free to get up and help yourself. In your folders today, there's more than usual. This blue card is the refrigerator card, and if you learn anything from today's sessions, some of our work starts here. We had this session earlier. The second item is your index for your family notebook, so you can begin to talk to your kids and family members. And we've had that, and we keep issuing it again. And each of you have an evaluation form. We'd like you to sort of pay attention to it. At the end, we'll be around. If you need a pencil or pen, we have those. And we really like to get these back so it gives us an idea. And there are a couple of questions on here, like, are you comfortable using the computer to do searches for information? And so we value your input. And it's also a question on here, which other seminars have you been to? And we tabulate these, and in October, we'll put together a plan and make a recommendation to the Community Affairs Committee and to the Board of Trustees. Today's program, we have 4 guests that are our speakers. They will be under a time schedule. We're not going to hold up a card or flash the lights or ring a bell like they do on television. But we want to leave enough time so there are questions to your questions. And we have a microphone so we can give you a microphone and everyone can hear the question. The first speaker is going to be Dick Brooks, one of our residents who's a doctor and has been experienced in many of these activities. The second speaker is Cindy Scott, who is the director of Hospice for the Vermont, New Hampshire VNA. And then next to her is Laurie MENARD, who's a social worker who's going to talk about Wish 5. And last but not least is Andy Ross, who is one of the directors of the Vermont Funeral Consumers Alliance, which is going to talk about some of the issues that no one wants to talk about. And she has a short video. So we'll move along, and I think I've covered up. Did I miss anything? I'll get Dick set up here shortly. You're on.
Okay. I think you have the slides in your handout. And we will have a Q&A following this presentation. So we will have a Q&A after we're all finished, so think about some questions if we don't clarify some of these things. But let me just start out by saying that there's been some studies done on people's wishes and how they would like to spend their last remaining days on Earth. And it's estimated that about 80% of people say they would prefer to die at home when it's their time. On the other hand, it turns out about 80% of people die either in a hospital or in a nursing home and extended care facility, or they may die suddenly somewhere else. And about a third of the people in the country, adults, do not, only a third have advanced directives or living wills. So we're hoping with programs like this and discussion that more and more people are going to enact advanced care planning. And I must say, after January 1st, doctors will be reimbursed by Medicare for discussions about end-of-life planning and advanced care directives, specifically. Heretofore, that hasn't been the case, and there's so much, when you see the doctor on your annual physical or any time, the last thing the doctor wants to talk about is spending time talking about these important issues that might be occurring in the future. So you can make a specific appointment with your physician to have a discussion about how to, what your wishes may be and how to start an advanced care planning if you haven't already done so. The first item I'm going to talk about is the selection of an agent, and this is by far one of the most important things with living wills and advanced directives, is to have one person designated as your surrogate, because the living will takes place when you are no longer have the capacity to make decisions about how you want your care to be. So having one person designated, now it could be, of course, a spouse, children, a close friend. It doesn't have to be in the family. It could be a close friend. And it is recommended that you only have one agent and not have, like, the children, because it gets rather complex sometimes when the doctor and the treatment team is looking for an answer as to what the patient's wishes might be. So that we'll talk about this later. The other thing, the second thing on the slide up there is the capacity for decision making. And what this means is that the doctor, the attending physician, taking care of the patient, is the one who makes the decision as to whether the patient has the capacity, is able to understand treatment decisions and what they wish to have done to them. So that's a decision that's made by the physician. And then if that's the case, if the patient doesn't have the capacity, then the agent is in charge. The agent takes over the decision making for the patient. And most agents, of course, will confer with family members and other people, friends and so forth, to come up with the right decision for that particular person. Now, I've talked about this before, but I think it's very important that we all have a primary care doctor, regardless of where we are in life. And the primary care doctor or provider, it doesn't have to be an MD. A lot of people now are going to groups that have PAs and nurse practitioners that are associated with doctors. So that particular person needs to have a good relationship with the patient and understand what their goals and wishes are. And I recommend if people are spending 6 months in Florida and 6 months in Quechee or wherever, that they have a primary care doctor at each location, because it makes good sense to have that anyway. Now, I have there listed hospital structure, who is in charge. I think if for all of us in the room here have ever been in a hospital, particularly in recent years, when you go, if you're taken to the emergency room doctor doesn't know you. They can get your medical record up if it happens to be in the hospital that your doctor is associated with, but they don't know you. So, but they make a diagnosis and they determine whether you're to be admitted or not. So you're admitted. Used to be in the old days, not too long ago, 10, 15, 20 years ago, your primary care doctor would be there to take care of you. Now that's not the case in most communities. And a physician called a hospitalist is usually the first one to admit you, and they've never seen you before. Maybe they did the last time you were there 3 months ago if you have a chronic problem, but chances are you haven't met them either. They know what your diagnosis is and how to treat you and so forth, but they don't really know you as a person. And a lot of times the hospitalist will confer with the primary care doctor by telephone or by email, or that's the ideal way, but that's not always done. And I think it's being done more and more. So your primary doctor may not even know you're in a hospital until you've been treated and released, and they generally don't come and visit you because they're not in charge of your care. So it is confusing in a hospital because you have multiple. If you go over to Dartmouth Hitchcock and you're hospitalized over there, you're going to have an intern who's going to work you up, write the orders, and take the history and physical. And you're going to have the attending hospitalist. You might have a resident who's supervising the intern. You have medical students who come and go. And then chances are you're probably going to have a specialist. If it's a cardiology problem, if it's a kidney problem, whatever, lung problem, the hospitalist will call in a specialist. So you've got another layer of physicians coming in, and it gets a little confusing if you're who's in charge here, who's really being responsible for my care. So be mindful of that, and certainly the agent should understand that as well, and usually they will. But that's important. But if your primary problem is cardiology related, chances are that's who's going to be managing your case, and that's the doctor's charge. The hospitalist may be there as well, but if it's a main heart problem, your cardiologist will be in charge. I have here, let's see, uncertainty in decision making. Doctors are. It's not always a black and white issue. There's a lot of uncertainty in our, first of all, the diagnosis sometimes, and then uncertainty as to how the treatment is going to be, whether it's effective or not. So it's not, there's always uncertainty with people in the hospital or people that are very sick and how they're to be managed. So what's true today may not be true tomorrow. So just be mindful of that. And the next slide, I have here shared, you may have heard of this term, shared informed decision making. Years ago, medicine was a paternalistic proposition. So whatever the doctor said, that's what would happen. That's evolved over the years to more of a democratic healthcare system where the patient has more responsibility, or should have more responsibility in their own care, which means that they should be part of decision making, providing that the doctor should and will, in most cases, say, this is what I recommend that you should have, this operation or this particular kind of treatment and so forth. And I think that the patient has to be somewhat responsible and say, well, doctor, what if I didn't have this procedure? What are the potential benefits? What are the harms? So then the decision will be based on that discussion. And so just keep that in mind, that each of us has now a responsibility to be more in charge of our care, long term, and even in the hospital and out of the hospital. I have here next palliative and hospice care. I'm not going to say anything specific because we have the experts over here in that area. But suffice it to say that hospice care is becoming more and more a part of our healthcare system. And along with that is palliative care, which is hospice in a way. They're the same. However, palliative care is being introduced earlier and earlier in patients' treatment. Hospice care, let me just say briefly, in order to be paid by Medicare, has to have a certification by the physician that the patient has 6 months or less to live, providing that the disease process goes on as predicted. And then hospice can come in and take over in the basic care of the patient. Palliative care uses the same fundamentals that hospice uses, only it can be introduced earlier in the process of a very sick patient who's undergoing, say, chemotherapy for advanced cancer, has lots of symptoms, and the palliative care team can be called in the hospital. That's where it's usually done, and make sure the patient's symptoms are managed as best they can be, and in consultation with the attending doctor who's treating the patient. So I won't say any more about that, but so the earlier the better. The palliative care is called in, the better. So many times you see a patient who has terminal cancer and the treatment is stopped and they say, oh, now it's time for hospice. They get on hospice and they're dead in 2 or 3 days. And they haven't had chances, the family hasn't had a chance to benefit from the value that hospice has. The next item I have there is clinician's order for life-sustaining treatment. That's a long title which really is to be applied at the end of life when the patient says enough's enough and I don't want to be resuscitated, I don't even want to go to the hospital anymore, I want to stay where I am, and the doctor can write an order, and you've heard the term do not resuscitate or DNR, that's part of it, so that's part of it, but it could be more specific, including patients not to go to the hospital. And there are different ways that the doctor can write this, but it should be in writing, and it should be visible in the patient's home. And maybe Dick, you'll talk about that with the putting it on the refrigerator is usually where something like that goes. The thing that happens so much in this situation is when a patient is being cared for by caregivers at home or even a nursing home, and the prognosis is the patient's going to die soon, but a caregiver is taking care of him, the patient deteriorates, didn't want to go to the hospital, didn't want to be resuscitated, and the caregiver sort of panics, calls 911, and the team comes and they try to save the patient's life because that's their job. But if there is a DNR order in the home, visible, that will not take place. Ethics committees, just a brief word about that. Most hospitals have ethics committees. They're comprised of physicians, nurses, social workers, people from the community. And they can be called in when there's a dispute about how the patient should be treated. Disagreement among the family and the caregivers and so forth. And they will help bring everybody on this, try to get everybody on the same page. And their decision is advisory. It's not, they don't make the decision. They can just be helpful in coming to a decision. Next slide. I just want to close with a few statements here that other physicians have kind of summarizes a very important measure. William Osler is the kind of the father of modern medicine. He was an esteemed physician who practiced at Johns Hopkins and in England and was originally from Canada. It is much more important to know what sort of patient has a disease than what sort of disease a patient has. This is kind of the bottom line of how a doctor views the patient. Next, Hippocrates. You've all heard of Hippocrates, probably the father of medicine back in the Greek era. To refuse to treat those who are overmastered by their disease, realizing that in such cases medicine is powerless. Even in those days, they had death with dignity. Primum non nocere, first do no harm. Physicians know about this all the time. A treatment decision may have benefits and harms most of the time. If the harms outweigh the benefits, then you don't do it. So first do no harm is basically how doctors tend to approach patients. If they know the patient's going to have exceeding symptoms and they're not going to survive, then they pull away. Next one. Question to always consider, we all should do that, what is most important to you about your medical care from day to day? So I'm going to stop right there. Hope I didn't use too much time.
book you have in your pamphlet, we gave Dick a chance to do a little. This program was started many years ago. Can't hear? Okay. Use the microphone, they say. Five Wishes program.
5 wishes you're able to put in your own words what you want or don't want.
You got ahead of me. The 5 Wish program is a nonprofit based in Tallahassee. Basically, it started by an attorney who worked to get the advance directives, which are now accepted in this brochure, if properly handled, is handled in 42 of the 50 states. And it's a workbook. And it's put in layman's language as opposed to, I see Bert Keenan here, attorney's language. It's a little bit easier to work on. We're not going to cover Wish 1, which is filling out the advance directive. We will do that. We did it last year. We will have another session on that. What we're here today to do is to really explain what your wish is when you cannot communicate. To the doctors, which Dick just covered, to your family, to your friends, and when the process goes, and there's about a five minute video here. It'll give you a little bit of an idea, and it's better than reading all the words, but take it home, and if you need another one, you need one for each person in the family. So if you want more, we have more copies.
Things that matter to you. And if you're one of the 78 million baby boomers in America with aging parents and grandparents, you'll find 5 Wishes helps you to be a good son or daughter to them. When their needs are known and stated in writing, you avoid needless disagreements and painful arguments among family members. Talk with your doctor about your care preferences. Give your doctor a copy of your completed 5 Wishes so that your instructions for care are clearly understood when the time comes. In this video, we'll walk through each of the 5 wishes and offer advice on how you may want to fill out yours. Wish 1 allows you to decide who will make healthcare decisions for you when you are unable to speak for yourself. Wish 2 discusses the kind of medical treatment you want and allows you to describe any medical treatment you don't want. Wishes 3 through 5 are what make 5 Wishes different from all other living wills and advance directives. These speak to what's in your heart, how you want to be treated, and what you want your loved ones to know. Next, you'll be given complete instructions on how to sign, witness, and file your 5 Wishes document. And finally, we'll answer some commonly asked questions about 5 Wishes. Let's get started. What was that? Now let's turn to wish number 2. Your wish for the kind of medical treatment you want or don't want when you can't speak for yourself. Wish number 2 serves as a living will. We begin with general instructions to your caregiver and stress the importance of good pain management, even if that pain management might leave you a little sleepy or drowsy. After giving general instructions to caregivers, wish number 2 then turns to the definition of life support treatment. The instructions include treatments that are commonly included in most states. Read the definition of life support carefully. We provide space within the instructions for you to limit the meaning of life support treatment in a manner that reflects your own personal or religious feelings and beliefs. For example, some people will specify that in certain situations they do not want artificially administered food and water, so-called tube feeding, to be treated as life support treatment. That decision is up to you. and it's a decision you make based on your own personal and religious beliefs, as well as your own wishes regarding the kind of medical treatment you want or don't want in any situation. We also give you advice about a Do Not Resuscitate form in the section entitled In Case of an Emergency. A Do Not Resuscitate order is different from the 5 Wishes form because it must be signed by a physician. It's typically given only in hospitals or nursing homes or to individuals with a terminal illness, and it deals with emergency care. Read that section carefully and talk to your doctor because you may need to fill out and have a physician sign a Do Not Resuscitate order as well. Make 5 wishes unique. Wish 3 talks about how comfortable you want to be. It gives you an opportunity to stress that you don't want to be in pain, that you want your pain managed. Now you may say, won't the hospital or nursing home take care of my pain? We hope they would, but it's important to make clear that this is what you want. America is good at curing people, but it's not very good at members. We also got a lot of wonderful feedback about Wish 4, the wish that lets you communicate how you want to be treated when you're seriously ill. Wish 4 allows you to say to caregivers and to others, here's how I want to be treated so that my God-given human dignity can be maintained. That matters to me. Wish 4 gives you control, even if you're not able to speak for yourself. It allows you to talk about your spiritual needs. You may want someone by your bedside praying for you or praying with you. You may want your hand held. You may not want to be alone, particularly if death is near. Wish 4 gives you that opportunity. Read each of the items and feel free to write additional pages on separate paper if you have other cares that aren't listed in Wishes 3 and 4. We give you ideas of care choices that you may want to communicate, but you may have your own particular wishes instead. Write them down. It's perfectly fine to attach those pages to your 5 wishes once you've filled it out. In Wish 4, you're saying, this is what dignified care means to me. I want you to know these things matter to me. Now let's go to Wish 5. Wish 5 is my wish for what I want my loved ones to know. This is unique to 5 wishes. You're asked to think about and communicate matters of the heart and soul, to talk about your love for your family members and friends and others, and to talk about forgiveness. Wish 5 gives you a chance to think about asking for forgiveness from those you may have hurt in your life, and it allows you to convey forgiveness. People get very creative with Wish 5 because it gives them a chance to communicate. Here's what's in my heart. Here's what's on my mind. Here's what matters in my life. There's also space in Wish 5 to communicate your burial instructions and to give advice to family members and others about a memorial service, specific readings or songs you may want read or sung during the service, or if you want a memorial service at all. At the bottom, space is available for you to describe your wishes for organ donation and any other concerns that we might call closure matters. It addresses all your closure concerns so that if sudden illness strikes and you're not able to speak and communicate anymore, you have written communication that states exactly how you feel. It's truly one of the best aspects of 5 wishes. Once you've filled out your 5 wishes, there's one more thing you need to do. You need to sign it and make sure you follow the instructions in the Signing the 5 Wishes section of your booklet. You also need to make sure that your witnesses meet the requirements that are listed in the instructions. Your witnesses should watch you sign the form in their presence. It's not complicated, nor is it difficult to do. Just follow the directions. Write your name, your address and phone number, and sign it in the presence of your 2 witnesses. Some people ask if your signature has to be notarized or not. Look in the box on the form that talks about notarization. Unless you live in one of the states listed in the box, you do not need to have your signature notarized. Now, if it's convenient for you to have your signature notarized, go ahead and do it, but it's not required by law unless you live in one of the states listed in the box. Once you've signed your 5 wishes form in the presence of 2 witnesses and properly followed the instructions, congratulations. You now have a legal document in your hands. You are now part of a growing number of Americans, millions and counting, who've completed 5 wishes. But there's
That gives you an overview of some of the work that we're going to be doing this afternoon. Jane and I have a 94-year-old cousin by marriage who lives alone on Cape Cod in a typical Cape Cod house, mows his own lawn on a John Deere tractor, and when his daughter, who lives in Mystic, Connecticut, comes up every 3 weeks to take him to the doctor for a checkup, the doctor's first question is, "Well, Harry, how are you?" He says, "I'm fine." End of discussion. He has a problem, and they happen to have 2 kids. Neither the two siblings do not agree on how to take care of Dad. And Dad doesn't want to talk to the 2 kids because he doesn't want to hurt one feeling versus the other. He wants to treat them equally, and so his will, trust, and everything has everything equal all the way down. And we showed this in Maine when we were together, and this gives you an idea of some of the issues that can happen. Our second speaker, if people need extra copies of this, Linda at the desk has extra copies. Cindy says she doesn't even need a microphone because her voice is strong, but Bill.
Thank you. I'm going to go ahead and stand, not because I want you to see me, but more importantly because I want to see you, and I can't see you when I'm sitting down. So, hello everybody, and thank you for coming. I want to thank Dick for inviting me, but most importantly, I want to thank Dick for inviting Annie. So usually, when I go to speak anywhere as a hospice professional, everyone's very squeamish when they say, oh, the hospice person is going to talk. So today, for the very first time in a very long time, she may get the honor of having the most squeamish presentation talking about funerals. So anyway, I hope I won't make it sound too awkward for you. How many of you had an experience, personal experience with anybody who's ever been on hospice? Okay, so a lot of you have had a personal experience. So I have been in healthcare for 40 years and spent 20 of my years working in the hospice and palliative care arena. So I've been with a lot of people over the course of my nursing career who have been very sick and who have died. And I think one of the things that I've learned the most, and what I hope to convey in the 10 minutes that I have, is that hospice is not about dying. Never has been, never will be. It is about living. And if your wishes are known and then honored, you are allowed then the freedom of living the way you want. So let's go back in time a little bit, and why did hospice even come to play? Since we have so many women in the room, I'm going to start by telling you that hospice started because of a love story. There was a physician in England who had a very dear friend who was very sick and was at her facility to be taken care of and die. He became very close to her. And she noticed that there were a lot of things that were happening to him that were not really in alignment with what her beliefs were. His pain wasn't well managed. He didn't get to talk to anybody about how he felt. He lived in isolation. And she said to him, I promise you, I will spend the rest of my career making sure your experience doesn't happen to somebody else. And she began to really look at what happens to people when they're sick. What happens to them? So Dr. Brooks talked at the very beginning that 80% of Americans, study after study, there was one recently done in New York, standing on the street, asking everybody that walked by, what do you want at the end of your life? 80% of the people said, I want to die at home. And they told the story about where and who they wanted with them, and it was all very lovely. But then what happens that 80% of people don't? What happens is we don't know what you want. Your family is often left to make that decision. They're anguished. They don't want to say stop things. You haven't had an open discussion with your physician in advance, and so we in modern medicine keep doing things to you. So prior to World War II, people died at home very naturally, and it was very normal. And then once World War II came, and we now have antibiotics and all of the things. My mom is from New Hampshire. She went to school at Boston Children's Hospital, and she's a nurse as well, and she was there when there weren't antibiotics and had a brother that died of an ear infection. So all of these things came about, and then all of a sudden our focus is now on fixing people. And what has happened in our urge to fix people is we've forgotten to listen to people. And that's, again, why some of the quotes that you have up there this afternoon is the physician's job is really to treat the human being and not the disease that they have. But we lost sight of that because we now had all these modern conveniences and machines and chemotherapies and radiation that did all of these things, and so we've pushed towards doing those for everybody. So what happens in hospice? So in hospice, our focus now is on asking the individual, how do you want to live the rest of your life? It is not about how do you want to die, how do you want to live the rest of your life? What are your goals? What do you want to accomplish? Now, a lot of people still think that hospice is in the last couple of days, and it's when people are taking their final breaths and all of those things. But the reality of it is, when they Medicare designed the benefit that pays for hospice, they designed it so people could have at least 6 months of this care, so that they could focus their time and attention on their bucket list, doing things that they want to do while they still feel well enough. The other beauty of hospice is that we actually have proven by study that patients feel better and do better, especially if you have certain kinds of cancer, COPD or emphysema, or congestive heart failure. The studies have shown those patients live longer when they come on hospice than when they're not on hospice. Why is that? Because a couple of things. One, we are no longer focused on aggressively giving you treatments or things that alternately make you sick. How many of you had friends or possibly yourself have had chemotherapy, radiation therapy, and know that it's a struggle. You don't feel well during that. And so when you stop those things, patients often feel better. Why does the congestive heart failure patient and COPD patient do better when hospice is there? It's the support of the team. Why do people end up going to the emergency room when you have COPD or CHF? For COPD patients, they go to the hospital because they can't breathe. They get very frightened when they can't breathe. So imagine now you have a lifeline in hospice where a nurse can come to your home instead of you having to go to the emergency room. Now we keep you out of the hospital and home where you said you wanted to be all along. For a CHF patient, what happens to them? Don't they get a lot of swelling? They gain a bunch of weight. And then all of a sudden they've got to go into the hospital and get some IV I wouldn't want to say diuretics, but that's Lasix, so water medicine. and so what happens with hospice? You don't have to go to the hospital to have that done. We bring it to you. You need IV Lasix? We have nurses that do that. So there's all kinds of things, and what I hope, again, that you'll get out of this today is that hospice is really about making people feel better, and ultimately they live longer. The other thing that I put a couple handouts in here. One of them is some facts about hospice that you might not know. But more importantly, I put in one called the Hospice Bill of Rights. So if we're talking about the wishes, the 5 wishes, I think that helps to put things in perspective. So despite the fact that I think hospice people were wonderful and were great listeners and we tried really hard based on this love story that started many, many years ago, we've made mistakes. We're a healthcare entity, and over the years, we've gotten a little pompous, and we began to think we knew better than the patient. Sad to say. And so all of a sudden, we began to tell people how they needed to die. This is what you need to do. This is how you need to do it. And guess what? In 2008, Medicare came back to us, hospice professionals, and said, oh, no, you don't. That's not what this was supposed to be all about. This was about what the patient wanted. So they mandated to us, you have to ask the patient what they want. So we now have guidelines in hospice that have always been there, but somewhat forgotten by us, that we have to ask the patient, how do you want to be? So let's talk about pain management. We used to believe that it was our job to go in there and give them pain medicine and make them comfortable and have their pain level at 0 because that's what we think they should have. And in fact, we even had regulations that said that patients had to have a pain rating of 0 or we're in trouble. Guess what? There are people who don't want a pain level of 0. Mostly men, sorry. But men seem to say, you know, I can tolerate a level of 4 or 5. I would rather have that. And so now all of a sudden our focus is on really, really listening to what the person says. So you may say to me, I'm going to, stay at home, but if I get really, really, really short of breath, I want to go to the hospital or I want to go to a nursing home. It is now our responsibility to honor your wishes. And we've gotten much, much better with that over the years. And I think this page here that I have, the Hospice Patient's Bill of Rights, actually spells out for hospice patients what your rights are. You have the right to make your own decisions. I had a medical director tell me a long time ago, people have the right to make their own decisions, even bad ones. Now, as a nurse, how many of you have a nurse in your family? Ooh, a lot of you. Are they all controlling? My husband tells me that all the time. He said, oh my God, I didn't know when I married a nurse I was going to marry a control freak. We like things our way. And so we tend to tell people how to do things. Well, we are now forced more and more into asking patients and families what they want. So the other thing that I want to close with, because I could go on all day and I don't want to, and you don't want me to either, is that when I talk about hospice being about life, I think most people, when I ask them, when I do presentations just on the hospice itself, and I ask people, describe for me a hospice patient. 99% of the people in the audience describe somebody who's bedfast, not eating anymore, and actively dying. The reality is, a hospice patient could be you, or you, or you. We really encourage our patients to be out and active and enjoy life. We've had patients that have gone on cruises. We have a patient in a couple of weeks that's going on a dinner date on a cruise at Lake Sunapee. We have patients that have gone on to the Grand Canyons, driven across the country with their kids with the oxygen in the back. We have patients that get married when they're on hospice. We have all kinds of things. So I hope that as I close, that your picture of the hospice patient is more like me. How many of you remember the physician or the educator from Carnegie Mellon who died of pancreatic cancer? And yes, thank you very much. Randy Posh. He did a presentation once where he got on stage and he did push-ups. And the audience was like, okay, what's this all about? He was trying to demonstrate that a dying person is still living. So he's still able to do those kinds of things. But if you were to look at his scans, if they were to put his x-rays and his CAT scan up on the board, you would see a man with disease everywhere that was obviously dying from that. His point of doing that exercise was to show to people, you can live until you die. You just need the right support. And I believe that hospice is the right support to enable people to do that. So I have with me today Lori MENARD, who's the social worker, and I asked her to come along because I think there's certain things that a social worker's role in hospice is very different from mine as a nurse. And so Lori's going to talk a little bit about patients and families and what kinds of things they want and at the end. Thank you, Lori.
Thank you, Cindy. So as a social worker, the nurses are kind of the bossy girls. I'm just kidding. But the social worker is the listeners. So we really have those hard conversations with the families and the patients. We're the ones who ask the questions that nobody dares ask. So we go into the family and we help support the family with a family meeting. Let's talk about this. Let's talk about your end-of-life wishes. What are they? And we did see the clip this afternoon, and they stole a lot of what I was going to talk to you about. So, so one of the first things that I want to share with you is if we think about living in our life, we plan. We plan for births of our children. We plan for a wedding of our family member. We plan for holidays, we're going to have a cookout, but we don't plan for end of life. So this talk today, I hope everybody really gives it a real, true, heartful thought to go home, gather your family, and say, we need to talk about this, because this is important to me and you. So one of the things that I wanted to share with you was when they suggested that, if you have 2 children or 10 children, that they aren't the ones who make sure, that you appoint to make your decisions for you. Remember, sometimes our kids can't do that. So it may not be a child who you ask to make those, to support your wishes. So, for an example, my daughter has experienced trauma with death. I know she can't make the decisions that I have written up for myself. So she's not the one to do that for me. Does that make sense? So I had to ask my friend, who I know would honor my wishes, because she won't be in the same emotional state that my daughter is, should I be at end of life. See, the other thing I just wanted to mention really quickly is when it comes to grief and bereavement, your family can go on. They've got to go on after you pass away. They can go on when they come back to, I did exactly what Mom wanted to do, have done. It wasn't my belief, but it was what Mom wanted. Mom didn't want this, but she wanted that. I wouldn't want that for myself, but that's what Mom wanted. So that grief and that bereavement is a bit easier when you can always say, I honored what they wanted. And then lastly, I just have a real quick story for you. Okay. So my mom is in her late 70s, and I've been doing this work for 9 years now. And so I said to my mother, Mom, we've never really talked about this, and she said, talked about what? And I said, what do you want at end of life? What are your wishes? What do you want to make sure that my brother and I do for you? Don't you worry about a young lady. I said, Mom, I don't mean it's going to happen tomorrow. She said, don't you worry. And I said, okay, Mom. Stayed another 20 minutes, and I'm walking out the door. I'm going to bury you in a pink dress. My mother doesn't wear dresses. So about 2 weeks later, she called and she said, I want to be buried in my pajamas. I said, what? She said, I want to be buried in my pajamas. I've decided that's what's most comfortable for me. And I said, and you shall be.
Annie Ross has the story and a very short video on end-of-life planning, and we're glad Annie is with us, and as a director of the Vermont
Funeral Consumers Alliance of Vermont. Yeah, thank you. Yes, I am on the board of the Funeral Consumers Alliance of Vermont, which I found out about a dear friend of mine in northern Vermont her mother was dying, and I knew that someday my parents were going to die. And I wanted to know, I had heard that she had taken care of her mother at home. Her mother had died at home, and she hadn't used a funeral parlor. Well, I couldn't really imagine my mother being whisked away by strangers and cut off from me. So I called her up and I asked her, what do you do? You know, I knew I had no clue what you do when someone dies, if you're going to do something yourself. So she told me about the Funeral Consumers Alliance of Vermont, said they were helpful in educating people about options you may not even know are available. So that's how I got in touch with this organization. So what we do is try to do some outreach and educate people in case you're interested in learning more and not having a funeral parlor do everything. And we also create surveys of prices for different funeral homes so that you're aware of what's out there. And an example is, a direct cremation at a funeral parlor might be $1,600 or $1,700, or if you drive a body yourself with a permit to a crematory in St. Johnsbury, it's $350. So there are financial considerations, and there are personal considerations. How much do I want to be involved in this passage of life of my dear loved ones? So I found out there were a lot of options I didn't know about. I could take care of someone completely without using a funeral parlor. So you have to be prepared for this. You have to have a transport burial permit if you need to move a body, which you can obtain. You might have to educate your town clerk because they're used to just funeral directors calling, but they can help you do this. They can give you a form. But you have to do all this ahead of time if you have any interest. It wasn't until the Civil War, speaking of how things changed, when there were so many dead soldiers in America that funeral parlors came into being because they had to take care of these dead bodies somehow. But before that, and in most of the world still, people take care of their own dead all the time. We have distanced ourselves so much from it, and it's really unnatural. It's very natural to die, and it's really okay to die. It's okay that all of us here in this room are going to die. It's part of the life cycle. And really, it's much more comforting to be involved with it than to deny it and run away and pretend it's not going to happen. It's a beautiful passage. It's a beautiful time to be present with your loved ones. And I will share the story of my mother passing and what happened there. First, I'll just mention, it's pretty complicated because in the family, you got to find that fine line, that point where you give up your own needs to cling, to hang on, to support the person to go. At some point, they could use your support for that. And can you step into that place? Leave your needs behind and be there for their passage. This happened to my cousin 2 weeks ago. He had lung cancer, had some surgery, and he was in the hospital, and he really wanted to go home. He really wanted to go home. He said he was really tired. But the family didn't want him to go home. They wanted the doctors to do everything they could, to save him. And so they put him in rehab. He was so tired. And he collapsed and died. No, he could have died at home. It might have been, a wonderful experience for everyone. But we have to be ready to face the fact that death will happen and that that's okay. So I'm a yoga teacher, and my yoga teacher told me something. I love this. She says, experience your experience while it is the way it is. experience your experience while it is the way it is. Be present in your life, in every moment, even the moments that lead and come to death. Be present. It's much more fulfilling. So I did bring you, we'll come back because I'm going to show you a little DVD and tell you about my mother, but there is an article in here talking about that, that relationship with the family and the doctor, and the doctor sensing the family doesn't want to talk about it, so they don't, but they know the patient might die soon. You gotta really tune in and sense how can I be the most support here? There's a wonderful book. So on the back too, you have a list of resources, and there's a wonderful book called Being Mortal by the Indian physician Atul Gawande. And this article is similar, this other doctor that we have. Also, the Vermont Department of Health is a very good resource in case you want to be more involved, and I mean, checking out what you need to do if you're not going to call a funeral parlor. Maybe you want to do it all. And there are ways to do that. So they're very helpful in that as a resource. There's as much to learn about the death process as there is about the birth process. And I'm not an expert on all of it, but I will tell you a little bit about the part that I'm more familiar with. And just so you know, there's also a copy of the death certificate in here. If you're going to be part of this yourself, you might need to know the deceased person's mother's maiden name or their social security number. So, you need to investigate a little bit ahead of time. It's things you might not know. So, let's see. So, my mother, we knew she was going to die. She actually lived 9 days without any water or food. And so she had a quilt on her bed, and when she did pass, then we rolled her over so that we could put the quilt under her, and then we could, 7 of us, a dead body is very heavy. It weighs a lot, even a small woman. So 7 of us took the quilt and rolled it up, and then we were all 7 of us could carry the body out the door, out of the building. And Jim, my partner, had made a simple pine box, and it was in his truck, back of the truck. So we had the permit way ahead of time, and I said, don't call 911. You have to fight your way to prevent some of these things from happening. You have to tell everyone, all the staff, everyone who would need to know. You have to tell them a few times. You have to educate them because they're only used to one thing. But if you like the experience, do you really want to pass that up? And maybe you do, and that's a fine choice as well. When I found out all of these things, though, I forgot to say earlier, I asked my parents, my mother and stepfather, I said, I found out how I can take care of you. And I can either bring you home and take care of you myself, or we can call a funeral parlor. What would you like? And my stepfather asked for a funeral parlor service. I said, fine. And my mother said, I can take care of her. And I said, fine. So, back to that little story then. So we all took part of the quilt and carried, almost like you carry a rug, carried my mother out and put her in the box, put the box in the truck. We got our permit, and we drove home. And we brought the box in the house for about 3 days. So there are details you might need to know. I mean, if it's summer, you'll need some dry ice or something. It was February, so it was cold. You need to keep the temperature down. There are all kinds of things you can learn, and these resources are on your resource page here. And then we had planned to take her to the crematory in St. Johnsbury, where you drive the body yourself. The body has to be in a box to be cremated. Also, you have to have a pacemaker removed, just if there is one, because it will explode in an oven. And it's very easy to remove with a hospice nurse. So that wasn't a situation that I was dealing with at that time. But it just so happened that the day my mother died, the guy up there, Les, was on vacation. And the woman who answered the phone didn't know how to deal with me. She wasn't used to anybody calling except the funeral director. So I said, you know what, never mind. Because it was going to be complicated. So I ended up calling Knight's Funeral Home in White River Junction, and they were very nice. And we used their crematory there, and we spent some time there alone in that room. And when we were done, we went to get him, and we stood there holding hands while the bodies of both my stepfather and mother went into the fire. And so after that, there was a service. I kept her ashes and we buried them on her birthday in November, a bit later. And I'll show you that part in the little DVD. After that, when I presented and told people about this so that they have some options if they want. It's okay not to choose anything. It's okay to choose anything. But we had a neighbor down the road who called. We did a presentation at the library, and someone there said, you might get a call from my friend in a week or so because their father is dying. So sure enough, we got a phone call. He had died the night before, and then they needed some help, and they didn't have any money, and they didn't know what to do. So we happened to both be home that day. Jim made a box. I got on the phone. We made a lot of phone calls, got the permit. I mean, all this takes a while. You really don't want to leave it to the last minute. But we did. We went and we picked up the body and put it in the box. The people were so happy. They wrote on the box. They made a little joke. They said, I told you I was sick. They said, oh, he would have loved those rope handles. And they were very, very happy to be there and be part of it. And then we drove the body to the crematory at St. Johnsbury. So, be with life and be with death. It's just part of who we are. There's nothing wrong with that. So I think we'll just close with showing you this 4-minute DVD. And let me just say, they were random photos taken. We didn't have any plan. We were burying the ashes where my parents requested the land where they used to live. We had the permission of the people who lived there. They had a lot of acres. So, and there were just some random photos. We put them together, and I had sung a song at the burial. It was a poem by Alfred Lord Tennyson, put to music by a woman named Ronnie Arbo. And the poem was written in 1870, I believe, and she put this to music in the 90s. And I have her permission to use the music this way. And I just thought it would be a nice thing, and somebody put them together for me, and I think did such a beautiful job. So I'll share it with you just to let you know. You can also create your own service, your own burial. You don't need to hire a lot of people. You can make it whatever you want. So we'll close with just showing the DVD.
Turn the lights down, and there will be question and answer for the next half hour till about 6. But please fill out your evaluation forms as we go through this.
This big one come off here?
Yeah, I think so.
Sunset and evening star, and one clear call for me. And may there be no moaning of the gulls when I put out to sea. When I night as moving seems asleep, too full for sound and form. When that which drew from out the boundless deep turns again home, turns again home, turns again home. When that which drew from out the boundless deep turns again home. For though from out our bourne of time and place the flood may barely find, I hope to see my pilot face to face when I have crossed the bar. When I have crossed the bar. When I have crossed the bar. I hope to see my pilot face to face when I have crossed the bar. When I have crossed the bar. When I have crossed the bar. I hope to see my pilot face to face when I have crossed the bar.
Now, who wants the first question?
In the Five Wishes document, there was a tabulation of states which accept this Five Wishes procedure. I noticed that Vermont is one of those states, however, New Hampshire is not. And New Hampshire, many of us have our medical facilities and primary medical care being taken care of there. What is there any acceptance in this document that Dartmouth got?
Bob, we asked the same question because we're in another location. The advance directive is accepted universally. What they do for the 8 states is the advance directive of Vermont, of New Hampshire. This is clipped to it.
We do have an
Yeah,
advance
so you
directive already.
you can add that. You can add that to it if you wish.
And it's accepted.
It's accepted.
Okay, thank you.
I have a frustration, and that is that the role of the hospitalist, I'm getting mixed messages about healthcare, that I should be developing a very good relationship with my primary care provider. And my assumption is that that would then benefit me if I'm seriously ill or in the hospital. Is there no, I understand the reason that they've come up with this hospitalist position, but are they not under any obligation to be in touch with my PCP? Or is it just willy-nilly?
It's an excellent question, and I think it's very variable. You can't assume that your primary doctor knows you are in the hospital. You can't assume that. And if you can always request, certainly the patient, family, or the patient themselves can make it be known that you wish to have your primary care doctor involved in your care. Now, so the hospitalist or the specialist who's taking care of you will still write the orders for your treatment and be responsible for your care while you're in that institution. But certainly they can talk to your primary care doctor. They can invite the primary care doctor to come in, and some doctors will visit. And they call it a social visit because they don't get reimbursed, unfortunately, unless they're called in as a consultant they'd have to have hospital privileges to do that. So it's, I understand your concern.
It's so contrary to the whole medical home model.
Right.
I mean, there's this
There
this
again.
gap.
We all have to be take responsibility.
Right.
And we have that right
Yeah.
to say, look, I want Dr. So-and-so to know about me being here, and I want, to have some dialogue between you and that doctor. It's
My other
perfectly a
concern-
fair
Sorry.
request.
My other question is about the medical records. I do not have relationship with docs at DHMC. I have another provider. And so while there's this big move towards electronic medical records that everyone is potentially sharing, there's a long way to go before that's a reality. Is there any online place where I could have my medical records uploaded that I could direct a hospital to, or is that just as difficult?
The question was asked last time, and there is, due to this confidentiality of medical records, you can't get them unless you sign a HIPAA form, HIPPA, for your doctor. And if your doctor is in a practice, it'll work for the whole practice. If you fill it out for the hospital, our experience on both of those counts, when we were in Florida this year, Jamie ended up in the hospital twice. And before we came home, and we have a family physician who's elected not to do hospital visits. She happens to have 2 or 3 kids, so she elected to be primary care in her own office, and she's overly busy. So when we went to the hospital, we ended up with not 1 hospitalist, but 3, depending on the shift they were on. But the hospital in Florida was all medical records were computerized, and she got copies of the treatment. But when we went home, we said, well, we want copies to bring back up here. Because Janie was then capable, she asked, and they printed out 4 1/4 of an inch of copies that you and I couldn't understand. This person could. But if I went to do it without her, I couldn't get them unless I had a HIPAA form. They happen to have the HIPAA forms right there for you. So it's a step that it's another one of these planning steps you have to do if the person you represent is unable to communicate.
It's a lot of work, but it's necessary.
Yes.
Hi, my name's Ellen, and I happen to work at Donna School. But one of the things that you can do wherever you're hospitalized or wherever someone you care about is hospitalized is before you leave, request over and over that they send a copy of the summary and give to the primary physician. So keep that primary physician's name, number, address. You know the family notebook they're talking about? There's one that we need to have for ourselves to carry around with us. Small, simple, but really you should always request at least the discharge summary. Because if you request that, it will have the greatest detail. And then the physician can go back to them and say, okay, I'd like to see these x-rays or those or whatever. But that may be helpful for you.
Thank you.
Okay?
Yeah, we're a long way away from having medical records that can be, there's so many providers of medical records. And someday, hopefully, the doctor in Florida or wherever can access DHMC record online. But it's not easy. Hopefully we'll get there someday.
The other thing to be aware of, though, and I don't think it came up today, is for the advanced directives that you do, or if you attach your 5 wishes to it, Vermont has a website that you can have them uploaded onto that is what's the word I want? Accessible nationally. Just so you know, New Hampshire doesn't, but Vermont has is part of a national website. And
It's
that's
called the
easy information
the
to get.
Vermont Ethics Network. We'll do that. And as far as living wills and advanced directives, physicians respect them wherever you made them out. If your attorney made them out or had them made out in Georgia and you're now living here, and you have a copy of that living will, it's honored by the doctors, whether they don't. And another thing is the doctor doesn't read your living will. Very seldom. I mean, it may be part of the record, but they're not going to study that living will. That's where your agent comes in. So whoever the agent is, you're responsible for your decision-making when you're incapacitated. They're the ones that has to interpret your advance directives. It's very seldom the doctor will read them and say, oh, I can't do this because of them. You know, they're not involved that way, but they are involved discussing with the family and the agent and so forth.
I have a question that I have yet to find the answer to. I've got all my documents in order. They're all got their I-dots on it and everything. What I'd like to know, if I were to kick the bucket tomorrow in my bed at home, there's a directive on the front door that says do this, that, and the other. But and I'm trying to avoid to get to a hospital, and I'm trying to avoid to get to a funeral parlor. Does one have to have somebody who says, yes, this person is dead? And who is it? And how does one get a hold of such a person before they cart me off to the ovens?
Good question.
I paid for it. You know, I know what I'm doing.
Yes. Well, first of all, the doctor has to sign a death certificate.
Yeah, but
Okay, but who says whether you're dead or not? That's what your question is.
yes, yes. So there is something that is a death certificate.
But the doctor's not going to come to the house and pronounce you dead. That doesn't happen.
So how
It's just the patient died. Everybody knows the patient's dead. They're dead.
But how do you get the death certificate?
Well, from the physician.
Where's the
Primary
physician?
Whoever's has been charged in treating your patient.
You know, if I drop dead tomorrow morning,
Right.
no physician around.
Your family would probably.
There's no family.
But somebody's gonna find you.
Who discovers
So
that you're
even
dead?
if it's 3 weeks later, somebody's gonna call the
Okay.
police, they're gonna come pick you up. And
Who's going to come and pick me up?
The police will send an
The police
ambulance.
will call a funeral home.
No, I don't want
Wait,
that.
let me finish, please. So if your information is right there, it'll direct them what you want. But if they were just to come to your house, find you passed away on the floor in the bathroom, the police would call a funeral home to store your body until somebody knew what you wanted. So
But it's
if
on the
you-
front door.
Okay, as long as they can find it, they'll take the
But
information.
there's
and-
no certificate of death.
That doesn't happen until you die.
Right.
You know, you have
Well-
to die, and then there's
I know, but who does
What's
it?
the
Who
process?
signs it? I mean, if it has to be a doctor, where the hell does he come from?
Do you have a primary doctor now?
Yes.
You do?
Yes.
Well, that's who
They
we
would do it.
That number has, that information has to be
On the front door?
Well, do you have an agent? Do you have someone who,
Yes.
they have to know who your doctor is?
Yeah.
Or should know.
I could say.
You need to talk to Annie about what
There are
happens.
three
What
things.
happened with your mother?
There are three things that you would have to have.
Can you use the mic, please?
There are three things that you would need to have in order. The first is the death certificate, which is usually signed by a hospice nurse or a doctor, and that can be done. Well, you do have one, right? So
No, she's not saying that.
yeah, we're all going to drop dead, but still, the doctor will have to sign a death. They have the forms.
I understand what you're asking. You want to know who's coming to your home. So if you were on hospice, the hospice nurse is doing it. If you're not on hospice, then like Lori said, somebody will find you.
Yeah.
And they will probably call the police because there's a death. And then they will say, you're dead.
The police has to make sure that it's a timely death and not a crime.
Okay.
So they would have to determine that first.
But they're not going to cart my body off to the hospital.
If you have a sign that says that's not what you want, they shouldn't.
Do the directions on your door explain what you would like?
The body is going to be picked up by the New Hampshire Cremation Society.
So once it's determined it's not a crime, they would then call the crematorium, the New Hampshire crematorium and say,
She doesn't
"You're
use that.
Quiet.
So
Not necessarily. If you've got a surrogate, somebody that's going to speak for you, she's saying she's all by herself. So that's why she's being so specific. Most of us would have somebody that would speak for us, or a lot of us do. You don't? You put a sign on the door. Nurses, we always say we're going to have it tattooed on our chest.
That's right.
And in New Hampshire and Vermont, the refrigerator is really the universal place that police, ambulance, and fire go to for information. So that's why you see those little red envelopes with medication list, or, I have 2 dogs, or I have 2 cats. Because if you're ill, say this lady here, she drops dead, but she has a cat in the house, but nobody knows it. So that cat remains in the house, not being cared for, because the police didn't know she had a cat. So make sure that information's included, but that's where they go. So if somebody calls 911, EMT show up, they're gonna scan that refrigerator for any information that they can take with them.
That was our first session. So if you haven't done it yet, it sounds like it's important. The second one is the index for the family notebook. And it's a good process. Jane and I did it with our kids in last September. And both of them are in the medical field, hoping to get some feedback from them. They said, if this is what you want, this is what we'll do. And then so we then had them implement. And in Vermont, when you list them on the computer, you get this little card, each of you, with a code. So, and they give you some stickers to put on your registration and on your insurance card in the car. So that if something happens, anyone can then code in the password, and you can read the full advanced directive on the computer no matter where you go.
What is the name of the place?
It's Vermont Advanced Registry. And if you go to the Vermont Department of Health website, it's an independent company in New Jersey. It doesn't cost anything. And they're very responsive. And then if you have a revision, you send the revision in, and you get another one of these, and then you sign it on the back. So it's a lot easier carrying this around than an advanced directive. And with the medical card, for those that go to Florida or Arizona, you need one there. Because the one up here has DMH, APD, the VA hospital, poison control center, and the emergency. It's no good in Florida or wherever you go. So this sounds like it's more valuable than it was a year ago. Any other questions? Yes?
Palliative care, how is it sanctioned by Medicare? And when can you go on palliative care?
You can go on palliative care at the beginning of your disease trajectory. So the difference, in a nutshell, between hospice and palliative care is payment source. Hospice, because it's a Medicare most of the time, and insurance companies pay for it, you have to have a prognosis of 6 months or less in order for Medicare to pay for it. Palliative care, you can find out tomorrow that you have cancer and start chemotherapy and get very sick from the medications, and palliative care can be involved helping to manage your symptoms. So it's all about making people feel comfortable while they're going through treatment. So somebody who has kidney disease may have a lot of side effects, nausea, itching skin problems. The palliative care team is really focused on keeping people comfortable, and they don't have the restrictions that we do in that you have to be dying.
And who pays for that?
Yeah. Who pays for palliative care? Who pays for palliative care at Dartmouth?
So palliative care is palliative care is sort of a specialist area at this point, if you think of it that way. And at Dartmouth, if you happen to have, you can request at any time from a physician that you would like to have a consultation with palliative care, and it's covered under your health insurance, whether it's Medicare or otherwise, as any of your consultations are. And, or it may just be included, I actually don't know specifically, but palliative care doesn't just work with people who might have something that we think of obviously as coming to a nearer end of life, such as a serious cancer diagnosis, but also people who might have, as Cindy spoke about earlier, you know, a heart effect that may be changing what might be how long they expect to live, or breathing types of issues, whether it's emphysema or whatever. So, I mean, you may have decades, you know, probably not decades, but you may have, you know, years to live still, but you're living with something that is always life-limiting and perhaps life-compromising. And so palliative care is there to help you actually think about your 5 wishes, think about your goals of, you know, how do I want to be living while I am coping with this health issue.
But that's not still answering the question of
So help, okay.
Who pays for it?
Oh, it's
I
covered
think-
by insurance because.
Yeah,
it's
it's covered under the
It's
insurance.
like it would be any
Right.
consultation. It's part of your treatment.
Yeah, a consultation, but what palliative care takes over?
So if you're asking, you mean if you were at home and had palliative care as opposed to hospice care? Is that your question?
Yes.
Okay. So, Cindy, if I get this wrong, let me know. In general, it's sort of a soft term. So if you're not choosing to have hospice care yet, the home health agencies, such as Cindy represents, provide nursing care in the home with nurses and social workers and staff who have an expertise in palliative care. And it is covered under your regular Medicare benefit because you need home care. Although you may then be, are you then under the restriction of you need to be homebound?
Under home care, you would be.
Right.
The problem with, let me just interject, the problem with cancer patients in the past, and I don't know what it's like now, but if the oncologist is giving the patient quote unquote curative chemotherapy to try to eliminate the cancer, and the patient can be very ill during this period of time, that's where palliative care comes in. Hospice can't. Is it still the rule that if they're getting curative care and they're not, even though they're close to death, I mean, could be, they can't qualify for hospice. And that's why the oncologists are reluctant to, have been reluctant to refer to hospice in the past because they could no longer give the curative type of treatment. Just, you know, maybe there's a 95% chance that the patient's going to get cured. And what happens is the patient deteriorates very rapidly, and they get on hospice and they're dead in 2 or 3 days. So palliative care is a good thing to have while the patient's getting the treatment, and they're not yet terminal, but they could be 3 months from now. So am I right about that? Yes. So think of palliative care as it's really hospice.
Advanced symptom management. So their goal is to keep you comfortable and manage all of your symptoms while you're going through treatment for heart disease, lung disease, cancer, whatever. They're very, very skilled at that because what happens is an oncologist is focused on one thing. That is curing you. I'm an old oncology nurse. I worked for years in an oncologist's office. And all day long, we are focused on your lab work and what the results of your tests are and whether the cancer treatment's working or not. We are not at that time, because our focus is single-mindedly curing you, we are not thinking about, gee, I guess the nausea's really bad and maybe you got constipated and maybe you got diarrhea. That's not what we talk about. Even when you come in for a visit, I'm not talking to you about that. That's why so oftentimes palliative care people who are focused on how you feel during this treatment, they are the experts and they do a tremendous job. And most of the hospitals now have a palliative care team at their hospitals as well.
It's 6 o'clock and some of you have some places to go and things to do. I think we'd like to thank Laurie and and Cindy and Annie and Dick for their time and presentation and information. And you're welcome to come up and ask individual questions and fill out your evaluation form. Just one comment on computerized medical records. Janie was on chemo when we got approval to go to Florida and have it done down there. And Dartmouth said, just send up the CAT scans. So we got the discs and we sent them up, and they called and said, we can't read them. And they said, oh, because we're using a different computer system and you gotta buy the software from Florida to get to Dartmouth. So we had to come back up here and do that process again. So, be aware. No, I know it's not our company.
Now, those of you who are moving, doing the 6 month here, 6 months there, it is worth before you go from one to the other. If you go into the hospital and they do any scans, ask them for a CD. It's free. They'll make it. They'll give it to you before you leave. Ask them for a CD of anything you've had. Because then you can take that and they can play it at the next place. Keep it as part of your personal medical records.
Can I ask a quick question? I tried to get a primary care physician here and was told Medicare will only cover one. So we couldn't have two primary care physicians.
Never had that question. We had two, one in Florida, one up here.
That's not right.
Okay,
I don't
the
think
doctor
that's
I
correct
called
either.
in was just saying,
No,
very
no.
knowledgeable.
You can have many primary care doctors if you want.
Yeah.
well, she said if you have a specialty, that's fine, but you cannot have two.
No.
Right.
Don't call them a
Right.
primary care. Doctor.